are, you guys can see. So if you look right over here where the pointer's kind of circling, you can see there's the mean and then there's the national. And oftentimes it'll be based off the specialty. So there's a national mean and there's a specialty mean, meaning pediatrics is compared to pediatrics. Anesthesia is compared to anesthesia. Yeah, they put in the national thing, but it's very important to look at it in comparison to what your specialty is doing, because you can't say all programs are alike, right? Neurosurgery is probably going to be a little bit different than internal medicine. And so you want to make sure that you're comparing it to the appropriate program. This is just kind of a general rule of thumb. You'll find this in no documentation, but it's a general rule of thumb. Typically what the ACGME does is they look to see, hey, how far are they off from their specialty? And so obviously there are bad years, right? There was COVID a million years ago and surveys tanked across the board, but they tanked across the board nationwide. They didn't just tank in one program. And so you take everything with a grain of salt and you look at it according to the specialty. Usually if you're about within 5% of the specialty mean, ACGME is not worried about it. If you're somewhere between 5 and 10, it's like, ooh, maybe there's a little bit of issue. If you're greater than 10% or 15 or 20% away from that specialty means, it kind of sets off bells and whistles. And so they're looking at this ACGME survey, they're looking at all the other objective data, and they're trying to measure, is there an early issue that we need to identify? This is how they really determine if your program gets a citation. It's also how they determine if your program is going to be put on warning, probation, or closure. And so 100% you need to be honest on the ACGME survey. But what I do ask you guys to take into consideration, if your program's identified an issue and they're sending out surveys or they're setting up listening sessions or they're talking to the chief residents or the resident forum, my recommendation is the best way to handle that without adverse actions for the entire program is if you can address it through those mechanisms and those modalities, I recommend doing that. Because once the program goes on warning or they've got extensive citations or they're on probation, et cetera, it's sometimes a little bit difficult to recover from that. Usually requires a site visit, which is super stressful. Yeah, it's stressful on the program director. It's probably most stressful on you guys, to be completely honest. And I don't want to put you guys through that if I don't have it, if I don't have to. The other thing that we started about 2 years ago is I meet with every program at least once a year. I meet with all the program directors. I meet with them a lot, but I definitely meet with them quarterly for new programs or programs that have disciplinary action. I meet with those program directors every other month. And once a year, I go to every program under our sponsorship. So I'll go to Durant, I'll go to McAllister, et cetera, and I'll meet with the program director. I'll meet with program faculty. I'll meet with their C-suite, so their administrators, and I'll meet with residents from each class. So I ask your program directors to set up some time so I can meet with the PGY 1s, 2s, and 3s of family medicine, the PGY 1s, 2s, 3s, and 4s of emergency medicine. I want somebody from each class because I feel like the issues at PGY levels are very different. It's different for a PGY 1 than it is for a PGY 4. And so I asked to meet with representation from each class. Super important at that point in time. I'm not there to do anything besides really determine how your program's going and if there are issues that I need to take up. Sometimes it's easier for me to go to the C-suite than it is for your program director. And so if I can find areas in your program that are not doing as well as I think they should be, then I can take that to the appropriate level. Sometimes it's the sponsoring institution, sometimes we need to diversify our resources, sometimes we need to do more investigation, sometimes we need to hold a special review. And so very important, we're trying to keep an eye on the programs so we don't end up having disciplinary action from the ACGME and we can keep improving the program. So I need you to hear me when I say 100% important that you are honest on the surveys because they'll know. If every single resident is saying, hey, everything's great, but you have an attrition rate of 50% and you can't fill your class, they're going to know something's wrong. So they're going to either know that you were coached or that you were told whatever it was that you're told. So very important to be honest, but if there are opportunities for you to resolve issues within the program or at the level of the sponsor, 100% important to do that. Does that make sense? Any questions about that? Okay. So what's expected of the residents? Clearly, I'm not going to go through every single expectation of every resident, but I want to just kind of hit on some of the highlights. How do you get the most out of your training? All of this stuff seems super intuitive, gets really, really easy to forget it when you guys get super busy. And somewhere between November and February, when it's dark outside, I feel like everybody kind of has lapses in these areas, but it's important for us to try to be adherent to these basic principles. Number one, be present. What do I mean when I'm saying be present? When you're on rounds, don't be on your phone, don't be on Google, don't be playing chess, has happened, on the phone. Really sends a message to your faculty, sends a message to the medical students, sends a message to your peers that you're not interested in being there. So be present. Even if it's a specialty that you're like, yeah, never gonna do this in my life again, be present because you're gonna get something out of that. And your career and your level of professionalism is evaluated against that. Be professional. What does that mean? A lot of different things. Showing up on time. Being dressed appropriately. Almost every single hospital has a dress code. Pay attention to it. Don't wear open-toed shoes. If your program doesn't want you wearing scrubs when you're actually rounding, don't wear scrubs. Be mindful about your appearance. It sends a message. The most important person it sends a message to is the patient. If you look like you just rolled out of bed, your hair's not brushed, your scrubs are wrinkled, your white coat has coffee all down the front of it, sends a message to your patient that if I don't care enough about the way my appearance is, why am I going to care about your care and how it's delivered? One of the biggest things I have an issue with as far as professionalism is the sometimes bad behavior I see between services. You know, it's really easy when you're frustrated and your census is really high to kind of make these flippant comments about other services, whether it be about internal medicine, whether it be about emergency medicine, whether it be about family medicine. Number one way to find yourself meeting with a professionalism committee. Not what you want to do. It is really easy to criticize someone when you are not in that specialty. And you guys heard Dr. Beeman and I talk for almost 10 hours about professionalism and the way we treat other people and the way we treat other services. 100% unacceptable to not treat everybody with the respect that you expect to receive. Other things that I want to just touch on, I hope I don't have to touch on it. Don't steal from the hospital. I say that because that has happened. Taking supplies home, that is taking it from a patient. Don't ask nurses to give you a liter of fluids because you stayed out too late the night before. Don't do that. That's a problem. Also has happened. You do not write prescriptions for your particularly controlled substances. Do not ever write a controlled substance for somebody that is not your patient and that you do not have a chart on. Specifically, it's for friends, specifically for your peers, specifically for family members. Don't do it. Obviously, I'm harping on it because it has happened. Be punctual, we kind of talked about, be prepared. Your patients expect you to be the most knowledgeable person in the room. And so does that mean that when you're done with rounds that you should probably look stuff up? Yes, it should be. Sends a message. It's also how we assess your patient care and your medical knowledge. You have gotten to a level where there has to be a lot of self-driven learning. There is only so much we can do. You know, you've got to meet us halfway. Can't give you the information about every single patient at every single second. And to be completely honest, this is the opportunity for you guys to develop those early career habits. One of the things that we used to do in internal medicine many, many years ago was we used to have to read 40 pages of Harrison's every week. It was awful. One thing that it did teach me was to be a daily reader. I read more now than I did as a resident. And that's because I have a responsibility to you guys, and I certainly don't want you guys showing me up as far as knowledge. So I make sure that I read every single day. You guys should do the same thing. Be a part of the institution that you're working at. The further I go on in my career and the further I go on doing this, there's really something to be said about if you have an issue with the way the system is working, if you're not willing to, number one, recognize how you're contributing to that system, and number two, try to be creative on finding mechanisms to actually improve the system, then you are not a part of the institution and you probably don't have a right to complain about it. I am totally okay and open for any resident to just be like, I think we could do it this way. The way you approach that situation and the way you handle the outcome, et cetera, says a whole lot to me about who you are as a physician and as an individual. So just make sure if you want something to change within the system that you're doing it in a professional manner. Be a team player. That means we help each other. We help other services. We help people within our own residency program. We pick up shifts. You know, those are things that go a very, very long way and you're going to be doing for the rest of your life. And then provide constructive feedback through conversation and evaluation. I cannot tell you how important it is that, you know, you guys want feedback, right? It's one of the biggest things I hear from the residents. Well, we didn't get enough feedback. Be mindful of what feedback is. Feedback can be happening and you could not be knowing it. It's the correction of, hey, I probably wouldn't have used cefepime on this patient. I probably would have used meropenem. They've had a previous ESBL, whatever the case may be. That is feedback. It's constructive. It's not meant to be punitive. It's meant to identify areas that you have in your medical knowledge or your patient care and to improve you. We evaluate you at the end of each month. You guys are supposed to be evaluating your preceptors at the end of each month. You're supposed to be evaluating the program. It is very important for you guys to provide feedback. Probably the most important thing, and I think the residents will say the same thing. It's usually comments or examples that help the system improve. It's not just like, all right, I've got to do this survey, so I'm just going to give them a 3 all the way down the board and I'm going to call it good. That does not help programs improve. So very similarly to you guys, we want to make sure that feedback is actually constructive and utilizable in the future. So how do we get you there? So competency-based medical education, you guys know all the competencies: professionalism, patient care, and procedure skills, medical knowledge, practice-based learning, improvement, interpersonal and communication skills, and systems-based practice. So kind of starting and going right around. So patient care and procedural skills, how do we evaluate that? I mean, that's day to day. That's how are you taking care of patients? Is it timely? Did you have to wait, you know, for your tending on every single thing? Did you start making decisions? Did that ability develop over time? Are you making the appropriate decisions? Are you starting to take into consideration all of the other nuances that come along with taking care of patients? Are you looking at their resources? Are you looking at where they live? How are they going to do this? How are they going to get here? So those are the types of things we look at patient care wise. If you're in surgery, how are you doing from your operative skills? Are you progressing? Are you progressing the way that you should be? For medical knowledge, we measure that a lot of different ways. We use it based on how you're doing on rounds and how you're actually doing at the bedside, but we also look at your in-service training exams. We look at the certifying pass rates. If you're a program that utilizes question banks and your program has access to your performance, we're looking at that as well. So there's medical knowledge, what you're gaining, how you're doing on the test, and there's patient care, how you actually apply the medical knowledge. Practice-based learning and improvement. This kind of goes back to the feedback piece. If I corrected you today on X, Y, and Z, and tomorrow you're still doing the same things, not really practice-based learning and improvement. How do you guys see yourself? How are you guys doing on your self-assessment? Is your self-assessment honest? Does your self-assessment mirror what the rest of your faculty are saying? Have you identified ways, instead of us telling you like, hey, you're performing like blank on your in-service training exam, have you come up with a protocol or a procedure that's going to help you self-improve? Or are you waiting for us to tell you every single step of the way? Residency is a really short time. May not feel like it, but it is a really short time. It's really important for you to learn those mechanisms to improve how you're actually learning and how you're retaining information and applying it in the future. Interpersonal communication skills and professionalism, those two things go hand in hand. Systems-based practice, how are you functioning in your system? Do you recognize that there are organizations outside of just what's happening in residency that impact patient care? You know, do you recognize that you're responsible to the licensure boards? That's part of systems-based practice. If you're having errors or deficiencies in the way you're practicing and you end up on a reviewable concern, do you recognize the implications of what that means for your license in the future? So systems-based practice is a very, very, very large bucket. Milestones, you'll hear us talk about this a lot. You'll meet with your program director. There's a requirement that you meet with your program director at least twice a year. And that is because your performance is evaluated by a group called the Clinical Competency Committee, which we'll talk about in the next slide. And you have milestones for every single one of these competencies. We take those milestones and we divide it into levels. So level 1, kind of a novice, level 5, expert. And so somewhere on that continuum, we evaluate you on those competencies. I get a lot of frustration from the residents when they end up getting level 1 and level 2s. If you were a medical student 2 weeks ago, you should not be at a level 5 in December. That doesn't make sense, right? Because level 5 says that you're ready to practice autonomously and independently. And I get all of this frustration. Well, I am absolutely not a level 2. Maybe you should look at what a level 2 actually means. It is okay for you to start at a level 1, level 2. Now you should be progressing through your postgraduate year, and it should be appropriate to where your peers are actually performing. And so very important for you guys to look at this, not as if this is a ding on your personality or who you are or how you're performing, or if you're going to be a good doctor or not a good doctor. You should take this opportunity to look at it for what it's worth and to see if you're actually improving throughout your training. So I talked about the Clinical Competency Committee. You're required to meet with your program director twice a year. That is an ACGME requirement. If it's not happening, I need to know. Your Clinical Competency Committee is made up of at least 3 faculty members. Those faculty members are responsible for reviewing 6 months of your training. So usually the program directors meet with their residents somewhere between November and January. They should have been evaluated from that July through December time period. Those evaluations help drive how the program director enters your milestone data into the ADS system, which we talked about, right? That's how ACGME is monitoring us. They're looking at the ADS. If they end up finding that every single PGY5 in a general surgery residency is performing at level 1, that's a problem. And so that data is sent over to the ADS. And so how do what type of data does the CCC look at? Here's a couple different things. They look at rotational evaluations, they look at semi-annuals, they look at case logs, particularly for those procedure programs, they look at your in-service training exam, peer evaluations, nursing staff, and other program-specific mechanisms. And so they take all of that data, they sit around the room, and they make a decision, and they're important decisions at this point in time, because they're gonna decide, hey, is this resident performing where they should for their postgraduate year level, or are they falling behind? They then give that information to your program director, and your program director has a very important decision to make at that point. Are you going to progress? Are you going to be put on an ILP, individualized learning plan? Are you going to be put on probation? Are you not going to get promoted? Are you going to be suspended? So the data that the CCC looks at is very, very important for your appropriate progression through your training. And so what happens if you're not meeting your milestones? Remember, the milestones based on all the competencies, and this becomes really important. Your CCC or your program director finds out that you have an academic deficiency or you have misconduct, whichever the case may be. There are 2 different types of correction that can occur at that point. One is a non-reviewable. Non-reviewables are like, hey, I'm putting you in ILP. What happens with that ILP? Usually the program director tells me about it. We kind of talk about it. We talk about resources to help you get you up to speed. At the end of a very specific period, which should be defined by your program, like, hey, in 3 months, we're going to evaluate if you've improved in X, Y, and Z. Sometimes they switch rotations. Sometimes they pull you off rotations. Sometimes they give you additional questions. Sometimes they give you assigned reading, a lot of different ways, depending on where your deficiency is. You come back at 3 months, the CCC reviews it. They're like, hey, resident's doing fantastic. They've caught up. We don't have any concerns. Resolved. Sometimes that non-reviewable is extended. Like, man, they are so super close, but they're not quite there yet. Let's do another 3 months. Great. We'll reevaluate in 3 months. Sometimes they step it up to something called a focused review. Still non-reviewable, and I'll explain non-reviewable in a second. At that focused review, they may say, hey, they failed Complex 3. Or, hey, their in-service training exam was awful, like they're scoring at the first percentile. We have a problem with medical knowledge. And so at that point, they may, if it's a testing issue, they may refer you to the Office of Academic Success at the university. Office of Academic Success for you guys is really for test taking. Some people are just not great test takers. And so we need to bolster your skills to make sure that you're hitting the scores that we think you need to hit so that you're going to appropriately pass your certifying exam in X many years. If at that point in time, so non-reviewables, what happened to them? They stay on your internal file. When you graduate, they're gone. Nobody knows about it. No future employer knows about it. No licensing board knows about it. No certifying body knows about it. It is 100% gone. And it was there strictly to get you where you need to be in comparison to what we expect the standard. Now, what if you haven't hit it? What happens then? Usually you go to what's called a reviewable concern. This is very important for you guys to know because reviewable concerns stay on your file post-graduation. I still get letters from people who have graduated like 15 years ago. Anytime you change your job, that employer contacts your residency program. It could be 20 years, it could be 25 years, the letter's still coming to the program. And the program has to say if you've ever been on a reviewable concern. What are reviewable concerns? Probation, suspension, renewal without promotion, meaning, yeah, we're going to renew your contract, but you're not going to get promoted to the next PGY level. All of those things are reportable. So not are they only reportable to your future employer, they are reportable to the licensing board. So if you're going to stay in Oklahoma, we have an obligation to let the Oklahoma State Board of Osteopathic Examiners know that you are on a reviewable concern. We also have an obligation to notify certifying bodies. So for internal medicine, AOBIM, ABIM, we have a responsibility, it's kind of written in the rules, to let those individuals know. So you can see when it's a reviewable concern, it's a big deal. Not saying that a non-reviewable concern is not a big deal, because if you don't fulfill your requirements and are non-reviewable, you go to reviewable. But reviewable concerns are very, very important for you guys to understand because they have implications for your employment in the future. Does everybody understand the basic gist of a reviewable versus a non-reviewable? Any questions about that? Okay. So important also, if you have a reviewable concern, most of the time I will tell you after a resident has gotten a reviewable concern, there's been a really long process. Remediation, 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 couldn't hit the milestones, couldn't hit the milestones, couldn't hit the milestones. So the resident's kind of aware that they're going down the path. If for some reason at any point in time, a resident and reviewable concerns 100% have to be notified to the DIO. You cannot get a reviewable concern without me knowing about it. And usually I know about it way before. If for some reason you believe that it is a reviewable concern without, I guess, just cause is probably the best way I can say it, there is a grievance process. This is what the grievance process is. It can be found on the sponsoring institution website. It should be in everybody's academic handbook. So every program has a handbook. It should be in your handbook. The basic policy is, I got this reviewable concern for whatever reason. And remember, it can be for academic and non-academic reasons. It could be a professionalism issue. It could be something egregious. It could be that you fraudulently documented on a patient. Don't do that. It could be because you entered a relationship with a patient and you absolutely shouldn't. That is 100% unacceptable at every point of your career. Some of those are so egregious that you totally skip the non-reviewable and you go immediately to the reviewable. And so just be mindful of that. But here's the grievance process. Like, hey, I feel like I shouldn't have gotten this reviewable concern. It is absolutely within your right to contact me and request my review. If you were going to request my review, you have to provide the evidence as to why it was inappropriate, and you have to give me a reason or a remediation that you think is appropriate. Like, here's what I think happened. Here's my evidence of why it didn't happen. And this is the course that I want to take going forward. I have the ability to overturn the reviewable concern. I also have the ability to sustain the reviewable concern. I will send that individual back an email within the timeframes that's listed here. If at that point in time, they're like, yeah, no, I need to go higher, it is 100% within your right to request a hearing. At that hearing, there will be other program directors that will review your case in its entirety to determine if they are going to sustain the program's recommendation or if they're going to overturn the program's recommendation. And so that's what we call due process. So due process exists for every resident at every point in time, but it is only for reviewable concerns. Does that make sense? Okay, very important for you guys to understand the difference between non-reviewables and reviewables, and that there's due process. Another committee that exists within your programs is called the Program Evaluation Committee. The Program Evaluation Committee is required to meet at least once a year. They look at all of the data that's accumulated for the last year, and they make decisions about what needs to be improved on the program. It is a requirement for a resident to sit on the Program Evaluation Committee. Programs should not be making decisions in a vacuum without resident input. This affects you guys the most. This is your training, this is your curriculum, this is your career. We want to hear your feedback. And so they look at a lot of different data points. Every program looks at different data points, but here are some things that they actually include. And then they're required to create an annual program evaluation. That annual program evaluation has to be reviewed by me. It's reviewed by me, and then I take it to that graduate medical education committee that we talked about earlier. They look at all the data and they make decisions about how the program is doing. In those decisions, they can make a decision about closing the program. Never happened. They can make a decision about if that program needs to go on an internal special review. What's an internal special review? It's kind of like a mini site visit from the ACGME. We interview residents, we interview faculty, we interview the program director, sometimes we interview HR, a lot of different people that we interview. Kind of a rigorous process because we are trying to move the benchmark of that program. Or they can make the decision, which I would say is 95% of the time, that the program can continue with their internal monitoring processes for program improvement. Couple rules of the road. This one always gets people in trouble. Not sure why. You have to pass Complex 3 or USMLE 3 in order to be promoted to PGY2. And that has to be done before June 30th. If you do not, the program has a decision to make. They can terminate the resident, and that's in the sponsoring institution policies and in the resident handbooks, or they can renew the resident without promoting them. And so important for you guys to have that in the back of your mind that by June 30th, for PGY1s in the room, June 30th, you have to have passed your third step of licensure, whether it be Complex or it be USMLE. And the reason that is because there is a rule that you have to be a licensed physician by the time you're PGY2. I didn't make that rule, that's a state rule. So there's no wiggle room. And so if you're not promoted, you will have a reviewable concern. You have to follow all GME policies and procedures. Some policies are applicable to all programs. Some policies and procedures may vary slightly based on the institution that you're at. Drug screening. This is another one that residents get really surprised about. If for some reason someone raises their hand and says, I think that individual is under the influence of whatever program you're in across the state of Oklahoma, you are subject, because you're a healthcare provider and you're a professional, you are subject to go for immediate drug testing. So if you get a call going down to HR and says, we're pulling you off service because you need to be drug tested, understand that is the employer's right because you're providing care to individuals that are a vulnerable population. And so understand that that's a big deal. Don't be under the influence when you're at work. You are subject to drug testing at any point in time. Duty hours, we'll talk about in a little second, and then evaluations. Make sure that you guys are completing your evaluations, just like you guys want feedback, the program wants feedback too. Here are the duty hours restrictions, a couple that get everybody tripped up. The first one on the very, very top is 80 hours per week, averaged over 4 weeks. And I harp on this a little bit because it comes up on the survey every single year for like almost every program. It is 80 hours averaged over 4 weeks. So if you worked 84 hours this week, but next week you work 60, and then 84 and then 60, and that's how sometimes, because of golden weekends, sometimes that's how the shifts play out. If over 4 weeks it is under 80 hours, you are still compliant with the duty hour rule. So just kind of remember that you're supposed to input all of your duty hours and new innovations. It tells us if you've had a duty hour violation. Don't lie on your duty hours. Found that out too with one of the programs. Don't lie, because there's something inherently wrong with the program that we need to modify. But this is what the rule is. It's an average over 4 weeks. Need to have 8 hours off between clinical duties. Clinical educational periods should not exceed over 24 hours. Sometimes it goes 5 hours. ACGME is not like living in a vacuum. They understand that sometimes for patient care that happens. 1 day off in 7 averaged. So okay, and this is another one that trips people off. Okay, if you are doing the 12 days on, 2 off, 12 days on, 2 off, you still have an average of 1 day per week off in 7. We talked about this up to 4 hours. ACGME doesn't live in a vacuum. Maybe added for effective transitions of care. So if you went 25 hours once, still okay. The other one, a review committee may grant an exception to an 88-hour work week based on educational rationale. That's really only applicable for neurosurgery. We don't have neurosurgery as a program, so not applicable to anybody in this room. The other piece is moonlighting counts in the 80-hour work week. In the sponsoring institution policy, if we find that you are moonlighting without incorporating it into your duty hours or permission that's granted by a program director, you can be terminated immediately. There is no reviewable process. I mean, there is, you can send it to me, but if I find out that you've been moonlighting without letting us know, because that impacts clinical care, 100% it is within the right of the program to terminate you immediately. Is that clear? Okay. Entering duty hours, won't go into this again because I just did. Do it. I know it sucks. You still have to do it. It's how you get paid. Evaluations, faculty are responsible for evaluating the residents. We talked about this. You guys want feedback. The program wants feedback. Residents are responsible for evaluating the faculty and the respective rotations. It is through evaluations on how we improve. It's how you guys improve. It's how the program improves. Mental health matters. Residency is tough. Probably going to be the toughest transition that you'll probably experience. It's not for the faint of heart. I get it. Life actually does happen outside of residency. Not everything is residency related. If you are struggling, please seek help. If you do not feel comfortable going to your program, 100%, anytime, night or day, you can call me. Most of you guys have my phone number. I put it up on that first slide. These slides are going to be available to you. 100% call me at any time. Because we can't help you if we don't know that there's a problem. If you feel like your peer is struggling, it is very important for somebody to raise the hand and say, I think we have a problem. Because like I said, we can't help you if we don't know that there's a problem. We've got parental leave, which we'll talk about. That is also applicable for your mental health. But we have systems in place to make sure that you guys can get the help that you need. Outside of the sponsoring institution, outside of this over here, almost every single employer actually, if you're employed by OC Medical Center, if you're employed by Talco Medical Group, they have an employment assistance program. People don't kind of know about that, but it's kind of like the best kept secret. They can help you with a lot of different things. They can help you with issues with alcohol or substance abuse, child or elder care, relationship challenges, financial or legal problems, wellness matters. And so it is very important for you, again, you may not know it, you may not feel comfortable, but we can get you to the right place at the right time. What if I have a concern that I want to report to the GME office? And that is a typo. That should not say Gary Slick, that should be me. As the designated institutional officer, there's that little orange thing that says resident feedback. Click on it. It does not go to your program. It goes directly to me. I have had issues that the people want to remain anonymous about. They have utilized this and we've resolved them. Pretty effective way. I ask that you go to your program first because your program knows the operations and knows the day-to-day. But there are instances in where people feel they can't go to their program. So parental leave policy, I kind of mentioned this already. It's really important for you guys to know this. This is the ACGME part, what the actual standard says, but we're going to talk about this because we incorporate it in. So why do we have a parental leave policy? And it's really a misleading name because it makes it sound like it's only for parents. But this is for individuals that are having a baby, have a spouse that is having a baby, or caregivers, for mental health. There are a lot of things that are incorporated underneath the parental leave policy, but this is the resident standing up and saying, I need time for X, Y, and Z. I've had a lot of residents that have requested time off for mental health or for needing to get things done, the death of a sibling, the death of a parent. There's a whole array of different things, and it falls under the parental leave policy that's on our sponsoring institution website. It's important that you do it the right way because it's also an ACGME requirement that I'm tracking it. And we have a mechanism to file it. So there's a form, super easy to fill out. You submit it to your program coordinator typically. Your program coordinator gets your program director to sign off on it. And then it's sent over to our leave tracker. The leave tracker makes sure that you haven't had multiple parental leaves. The rule is you can take 1 6-week parental leave during your training or 2 parental leave trainings that total 6 weeks. Has to be a minimum of 2 weeks, or you can just take it through vacation. And like I said, 1 6-week or 2 separate leaves that total 6 weeks during your training. If you take 6 weeks off, you will still have 1 week of vacation. If you take 5 weeks off, you will still have 1 week of vacation. If you take 4 weeks off, you'll have 1 week of vacation. 3 weeks, you'll have 2 weeks, and 2 weeks, you'll have 3 weeks. I know that's confusing, it's in the policy. But we try to make sure that on top of your parental leave, you still have some vacation that you can use for PTO. Salary and benefits have to be paid for that 6 weeks. So that means if you're taking 6 weeks off, I don't want you guys to worry about not getting paid. I don't want to worry about your benefits. Those will 100% still stay intact. If you are going to take time off that's longer than 6 weeks, that will go through your FMLA process that's designated at your specific institution. And so it's not saying that you can't take more than 6 weeks off. What we are required to do is provide 6 weeks off for each resident at least once during their training. If you were taking, and this part gets a little bit tricky, if you were taking time off for mental health reasons, and this sometimes people are like, God, that feels punitive. I promise you it's not punitive, there's a reason. We sometimes require a fitness for duty evaluation before you return. What is a fitness for duty evaluation? It is the employer's way to make sure that you are ready and able to provide safe care for your patients. It's also a mechanism for us to make sure that you have recovered and you have the mental fortitude to go back in residency. Like I said, residency is probably going to be one of the hardest things that you do. We have to make sure that we're protecting you. Your mental health matters to us, and we also have to make sure that we're protecting the patient. And so just understand there's a checkbox that says, I understand that I may be required, if I'm taking leave for mental health reasons, I may be required to do a fitness for duty evaluation when I return. We will walk you through that process and understand that it's very important for us to know that you're personally safe and our patients are safe as well. Moonlighting policy, program specific. Means the program gets to decide, please do not send me emails that you don't like your moonlighting policy. I can't change it. Moonlighting is a privilege. It is 100% not a right. There are specific programs in our institution that do not allow moonlighting. That's okay with me. Your number one priority is to be a resident. I've already kind of told you, you have to have permission from your program to moonlight. You cannot exclude hours that you're working and moonlighting from your duty hours. They count. 100% terminatable offense if you're doing that. We kind of talked a little bit about this too. What if I notice someone's fatigued or I'm too fatigued to work? There are mechanisms that we have in place, whether it be the employment assistance program, whether it be parental leave, but we need to know if somebody is too fatigued to work. How your faculty do. If you notice somebody that's like super burnout, it is important for you to kind of raise your hand, go to your chief resident, go to your program director, go to a faculty member, come to me. is very important that we're aware so that we can prevent bad things happening to either the resident or to the patient. There's one other thing that I meant to mention over here, and I totally forgot. You are eligible after you graduate to sit for either the ABMS boards or the AOA boards. They're one program, need to point out, the ABMS has a very interesting rule for internal medicine specialties. So internal medicine, gastroenterology, cardiology, interventional cardiology, that the program director has to be ABMS certified. Currently right now, the only program director that we don't have that's ABMS certified in internal medicine specialties is the GI program. Those fellows have to take the AOA boards because the ABMS precludes anybody who is AOA certified from sitting from their certifying exam. Doesn't matter for internal medicine, doesn't matter for cardiology or interventional cardiology, but if you are a GI fellow, or if you are an internal medicine that is pursuing a GI fellowship, understand that that rule exists. It's probably best practice for you to sit both for the ABMS and the AOA boards, just depending on what it is that you're choosing to do next. Okay. Questions about anything that I have talked about? Okay, well then you guys are free.